Today I'm here with Professor Eric Kandel and Dr. Tina Moen and Dr. Sean Pakbaz and Professor Laligam Shekhar. We are going to talk about brain mapping and therapeutics and artificial intelligence. So it's a great pleasure to be on the panel with you, and I would like to turn the discussion to Dr. Moen and see what's your thought in terms of how AI could actually help brain mapping and therapeutics in terms of neurological disorders, and what Watson Health is doing at the moment?
Sure. So I think the real key to applying AI to help solve problems and help people make more effective and more educated decisions is really the ability for AI to see through and across large amounts of data. Mm-hmm. And so in a topic like neurologic disorders and brain mapping and how to treat patients who are suffering from afflictions such as that, it's identifying the bodies of evidence and bodies of data that currently humans or perhaps even other advanced analytic techniques are mining this data, but oftentimes separately, the structured data versus the unstructured data. So applying AI to multiple data sets, structured and unstructured, in the subject of neurologic disorders will marry those two kinds of data together, which currently human beings are doing, and marry those two kinds of data together and surface insights much more quickly and at a speed and a scale that humans can't.
Excellent. Dr. Kandel, what's your thought in terms of using AI for psychiatric disorders?
I think it would be very helpful, particularly in marginal cases. It would be really a definitive diagnostic procedure. For example, people sometimes are sad. They may be sad spontaneously, or they may be sad in response to a loss of some sort. When is that sadness that is normal transformed into a sadness that is pathogenic, an actual depression? And I think it would be extremely helpful in the early stages to have AI as a partner in the decision making. So I think there are a number of cases where at the margins AI will be tremendously helpful.
Excellent. Dr. Pakbaz, you are already integrating some of the softwares, AI softwares in neurointerventional radiology. Can you talk about that a little bit?
Sure. So AI can be used in gathering data, coming up with formulation of a plan, or also it can be used in actual technology. So we're able to use it to predict what part of brain could be potentially damaged, or stroke has already taken effect, or use it to visualize things, such as rapid transfer of data, crunching algorithms, or being able to look at large numbers of cases and predict what part of brain is affected. For example, in the area of aspect score, there are already companies that can get CT scans, and the machines have learned from large sets of data through previous experiences that the areas of affected brain. So machine learning can predict the aspect score.
Dr. Shekhar, how do you think we can use machine learning for skull-based surgery, neurosurgery in general?
You know, artificial intelligence and the combination of AI with robotics is going to have a tremendous impact on neurosurgery. I'm just going to highlight two areas. The first is the area of decision making. You know, for instance, today, if you have a patient with a brain tumor, or you have a patient with an infection in the intensive care unit, or let's say a ruptured aneurysm, the neurosurgeon is making a set of decisions. Stroke is another area. However, the available data are constantly changing. There's huge volumes of data there. Some of the data is good and some of the data is not good. So it's up to the physician to read this information, digest all that, and make the right decision. So I think that AI can help us in gathering information in a real-time fashion, but also applying decision-making algorithms and help guide the physicians. Not tell them, but maybe tell them in a very gentle way to make the right decisions. For instance, today, all of you, when confronted with an issue, you whip up your iPhone and you go on to Google or Bing or whatever, and you look for information. And I see 10 years from now, we're going to be doing this with implanted epidural electrodes. There will be a group of cyber doctors that, when they think it, they will ask the question, and it'll connect with a cloud, which is enabled with AI, and they're going to get the answer within a minute or within a few seconds, if they be. So that's the area of decision making. I think is going to be very important. The second area is what I call patient follow-up. So we have a lot of problems with the follow-up care of patients and just healthcare in general. There are tremendous demands on personnel. So when I operate a patient and I discharge a patient, ideally, I'd like to see that patient every day, or maybe twice a day, just to see how the patient is doing. But from a practical point of view, it's just not possible. So there is a nurse practitioner or a physician assistant who's going to see that patient 2 weeks from now. We give the patient a set of directions to follow. The patients sometimes realize the importance of that, sometimes they don't. But imagine if you had a chatbot that will communicate with the patient twice a day and see the needs of the patient, maybe even look at their picture using facial recognition algorithms, etc., look at their wound and so on. That can be a big help. And this can also be applied to chronic disease management, such as diabetes, high blood pressure, obesity, etc., a variety of things, heading off stroke at the pass. Before big strokes happen, if a patient has symptoms, that can be screened by an AI-enabled chatbot, and it can be made readily available. And that's going to be the key, the availability of such technology to all humans at a very low cost. If it's only going to be available to a few isolated rich people, it's not going to help us.
That's an interesting point. Dr. Mohan, where are we in terms of integrating this technology into a surgical platform or any of the diseases that are out there? Today you talked about ALS, and there was a discussion about autism and psychiatric disorders. So where are we now, and where we will be in, let's say, 5 years or 2 years?
Great question, and a little bit tough to answer because of the speed of technology development. But so today, Watson Health, as I mentioned earlier, is a 3-year-old organization, and really the world lies before us, if you will, and by us I mean those of us in healthcare. Where do we start? What's next? There's almost so many places to start that we need to be quite mindful of not trying to do too much at once. So today, as I mentioned, we've got the great ALS example with Barrow Neurological, but also a variety of applications in things outside of neurology, and sort of expanding into subsequent and related therapeutic areas. Psychiatry and mental health is a fantastic example, with depression being associated with so many other chronic disease states. And how do we start to find the patterns between something like diabetes and a diabetic patient who is depressed and who is not depressed, and how those patients present and what might look different, and then perhaps making recommendations on how we would treat them differently to address both chronic conditions. On the surgical front, I think that there's still so much effort going around from our perspective around how to capture and analyze and bring up insights into areas more on the therapeutic side, that surgical is on the horizon for us still. But certainly, as our colleagues here on the panel have said, there's a lot of promise there.
Yeah.
One very interesting application that just dawned on me, which is rather humorous, and that is in the evaluation of transference. That is, when a physician presents to a patient when a patient presents to a physician, he projects onto the physician certain ideas, and the physician has to take that into consideration in the treatment of the patient. This is particularly important in psychiatric context, in which a patient often takes many aspects of his illness and projects it onto the physician. And the physician has to be comfortable with that and to interpret that for the patient so the patient can see what is reality and what is not. And to have objective evaluation of how this transference is developing and how it's being evaluated on both sides will be absolutely essential. Because it's clear, everybody's had this experience. In some cases, there's a very good fit between a patient and a therapist. In many cases, there are lousy fits. So if we had some objective way of evaluating this and helping both the patient and the physician see that this is not working well, you should seek another therapist, would be very important.
Yeah, I think that's a great point. And in neurosurgery, we are now basically starting to use much more real-time imaging and use different spectrum of light to detect cancer, as we discussed over the poster, and integrating this data real-time with the preoperative data that exists, from MRI and data from the patient's record, could actually give us a very precise way of mapping the abnormality, and with the precision that we get from that data, we could actually have a very effective surgery. So I'm just wondering, in terms of data integration, what's your thought as in terms of integrating the imaging, in terms of MRI preoperatively, with intraoperative data from, let's say, photonic data and patient record? Is RBM Watson moving to that direction? How do you integrate this data, and how real time it can be?
Absolutely. I think there's been some work done, not in neurosurgery to my knowledge, but around cardiovascular imaging and identifying aortic stenosis, for example, and how some really great results have come from combining both what the AI system can see and comparing that to what the physician does or does not see and records as a diagnosis for a patient, along with text and unstructured data in an EMR, a patient's record. Again, what a physician and care team have documented for a patient, building those two things together, combining those two things together, and again, surfacing insights for patients who perhaps have all the key things, whether it be in their image of their valves or in their data about them, merging those two things together and identifying patients who weren't otherwise diagnosed with aortic stenosis. So that sort of approach can certainly be then duplicated for other combinations, other areas of the body, other things they're looking for, and marry that structured data, unstructured data, along with image data to help a clinician best understand what's going on with their patient and make the best recommendations for the patient.
And how do you do that? You do that on a cloud system? You do that individually in each hospital? Can you tell us how do you do that?
Yeah, I'm not a technologist, but yes, data out on the cloud and or on-prem if that's a client's preference, depending on firewalls and local laws and things like that. But bringing data together and as one of our colleagues mentioned, the veracity of the data is important, and ensuring that that you've got appropriate volume to make viable decisions, and you've got appropriate veracity to make clean decisions. Put that out on the cloud and apply the technology, and after it's been trained on the subject of the target subject, and surfacing insights to provide back to a decision maker.
And so, in terms of Watson Health, I'm just wondering, because none of us have a data science background. So if this is rolled out, is this something that requires training for physicians, when to acquire data, how to acquire it, when to share it, how to share it, and this is very important for scientists to know, and we are not really trained for that.
Yeah.
Physicians are not trained for that. Just wanted to seek your thought about that.
It's interesting. We were talking earlier about that there's an evolution of roles that will happen and has been happening over time with technology and people's professions. And this is another example of that. Folks who understand the language of healthcare, in this case, the language of neurology, working with organizations like ours to train the AI system so that then the end user, the physician at the patient's bedside or the scientist at the bench, does not need to be a data scientist, but their organization, when partnering with companies like ours, their organization needs to understand their goals and their objectives, the kinds of data that they have. We can work with them and partner on the kinds of data that they may need, that may benefit and add to the decision. But certainly the goal would be to have the end user not need to both be a neuroscientist
Yes.
and a data scientist
exactly.
and an expert on every other subject.
For example,
I had another question from you, actually, to bring you to a conversation. I want to know, I mean, you are somewhat doing this cloud data sharing in your platform.
That's right.
So I'm just wondering, what are the problems you're now having in terms of, let's say, HIPAA violations, or in terms of data sharing, and pixelated MRI and so on?
I think that one of the things that are happening, actually, many of the providers have already addressing that issue right now with us, with Google coming up with new ways of communication that are much better secured, as well as other platforms that are now coming out. That problem will solve itself in a short period of time. They've come up with ways that we can actually use HIPAA compliant technology for that purpose. But for storage of the data, we're right now using actual facilities that keep people's credit cards informations and people's private informations, and it are very secure, maybe more secure than actual hospitals keeping their own information. It's much easier to break into hospital information. But as a whole, as we were discussing in regards to the data, and one of the areas that we're interested in is stroke. And stroke, a lot of these are caused by atrial fibrillation. So atrial fibrillation, we now have devices that we can put under the skin, and they can evaluate every heartbeat of a patient, right? But that's an enormous amount of data for every patient that goes on. 800,000 new strokes every year. You can see that we need actual machines to flag which heartbeats are abnormal, which areas are abnormal, and then pass it on to the appropriate doctors. We're going to run out of cardiologists very, very quickly here with evaluating everyone's heartbeat. You were talking about Fitbit.
Right.
That's also very similar to putting devices in that. All that data has to be interrogated by someone, and it's not going to be humans. We're not that capable of carrying that much information and interpreting. We don't have enough experts to be able to manage that.
Correct.
So we do need artificial intelligence. We do need machine learning. We need predictive algorithm to be able to come in and sort out which patients actually will need some type of a treatment. There are now devices available that can predict someone going into congestive heart failure. Wear a necklace and it evaluates impedance, and we can give a medicine ahead of time. So, hey, don't go into congestive heart failure. You can get this Lasix. So that's where I think AI and what Watson and its information can really come in and help us, because we're unable to crush that much information.
I think in the World Congress here today, there are presentations from a group that come up with a technology which could predict a seizure before it happens. Mm-hmm. So it can give a signal to a patient that you're about to get a seizure.
Absolutely.
And that is life-saving if you're driving. Sure. So the devices are becoming intelligent as well, so kind of an internet of everything. But I think I would like to ask from Professor Shekar, what's your thought on kind of the ethical ramification of this? Do you do you see any challenge in this technology?
Well, one of the two issues I'd like to address in this regard, the ethics of it really come down to what is the right thing, what is the right outcome for the patient, and the other aspect is job creation or job loss. I think that if we keep the central goal in mind, what is the right thing for the patient, the right thing for the patient is not simply the right delivery of healthcare, but also cost, because in the end, if you have a certain budget, every population has a budget, and you want to develop or deliver cost-effective healthcare. For instance, my colleague was talking about patients who have had strokes that cannot be helped. It's too late to intervene, or so on. And that patient gets transferred to the major center, and the whole thing is wasted. We have tremendous amount of waste in the operating room and in the hospitals because we are doing maybe sometimes the wrong tests. Inventory is being managed poorly, etc. There's tremendous opportunities there to incorporate AI and reduce costs. So that's the one aspect. Which is basically comes down to delivering the right care, but also cost-effective care. The other aspect is what is our responsibility to healthcare workers. As you know, in the USA right now, healthcare work is considered to be one of the top employment opportunities, perhaps along with computer work and so on. And I see that this is going to change tremendously. I don't know if the jobs are going to disappear, but certainly they're going to change because all the janitorial and lower level functions are going to be better done and more efficiently done and by AI-enabled robots in the years to come. So hospitals will be forced to use them. But then how do we prepare our workforce? How do we prepare our population for that to happen? We're just not doing that because our politicians are simply not in touch with what is happening in technology. There's a huge divide between these group of doctors, like our people sitting here, the computer people, the tech expertise, massive amounts of tech expertise we have in the U.S., and the politicians who never took science, or they don't believe in science, they don't believe in evolution, etc., on the other side. So we need to bridge that. We need to communicate better to the young people. Because they are the population of the future. How do we get there?
That's a great point. I was going to bring that to you because last night at the board of directors meeting, we had a politician in our board come to the board, and it was an assemblyman from California, and we talked about how do we actually communicate this technology to public, maybe through a brain channel, but also educate policymakers. Your thought on this?
Yes. So to have experts come in and speak to policymakers and show them what options are available. But I think the most impressive way to convince someone of a new direction is to show that it works. Mm-hmm. So if the Mayo Clinic picks it up, or if Columbia Presbyterian picks it up, and all of a sudden can do something that other hospitals can't do, treat patients more successfully, get them out of the hospital earlier, not even require hospitalization for certain illnesses who are inevitably hospitalized, that is going to affect every other hospital in the country. Mm-hmm. I'm overstating it, but there's nothing like a clear demonstration by a medical center that we're doing something that we didn't do before and has had a fantastic impact on the kind of healthcare we can provide.
I think that is good and is inevitable. That's already happening in every field. Sure. But the problem that we have in the U.S. is that there's a population that is getting left behind constantly. You think about renewable energy, this is the clear future for America of the whole world. But then we are still defending coal because we have a whole bunch of coal miners and we have other people. We have people that have no education. So we need to find a way to reach out to these people and bring them into the fold, into our fold. Otherwise, this divide is going to become bigger and bigger.
But this is an issue of the country as a whole in many, many areas. And what you need is a government sensitive to the poor, which our government is periodically in its history.
Mm-hmm. But I also venture to tell you that it may be job of our scientists as well, because companies like IBM can make jobs for people who are not skilled.
Yes.
Companies that can actually simplify the jobs that need monitoring. For example, in the areas of security, in the areas you can be sitting at your house now and monitor 5-10 different places, and you don't need a great skill for monitorization or other areas. Or you mentioned janitorial function. That robot will need a supervisor. That very person that is low skilled can learn that, and it's a job of our IT and technology companies to make it simplified enough where we don't need a computer engineer to tell that robot what to do. We need that interface where low-skilled people can actually operate high-skill equipment. And that's where I think that the gap will close, as opposed to making it harder and harder and needing a computer science degree to be able to operate the simplest things.
I think the social responsibility is another aspect of this now. I would like to learn what IBM is doing in terms of social responsibility here.
Absolutely, I think you're right. I think as I mentioned earlier today, Ginni Rometty, our IBM CEO, talks about this idea of a new collar job. And our responsibility to support those new collar jobs in the world, not just in the U.S. In fact, we have an initiative now reaching out to folks individuals who maybe aren't college educated in a particular subject, but who are interested in just as you're saying, roles that haven't been in existence yet, a new collar job, and how we help prepare the industry to support the new technology that's being developed in all sorts of industries, not just in healthcare, but healthcare included. But I think to your point earlier about the evidence that it has worked somewhere is something that's very near and dear to our hearts as well, and driving a philosophy of data and evidence, particularly in healthcare, because it is such a pivotal point in how we all make decisions about whether things to buy for an organization or how to treat a patient. So doing proper studies with our partners at Mayo Clinic and on clinical trials matching or MSK and oncology to demonstrate sort of through the path of this developing technology first, that Watson is making appropriately clinical recommendations and agreeing with a physician recommendation, and then, moving up through the hierarchy to the holy grail of outcomes. Very important that there's, third-party objective evidence that technology, whether it's ours or other technology, works in healthcare. So I completely agree that proof is in the pudding, right?
Yes. And with something like the Mayo Clinic, if it adopted some of these things, and it's in excellent position to do this, they could show within a reasonable period of time that this has dramatically improved the quality of healthcare that we can provide.
Well, it's a great pleasure to have a fantastic panelist, Dr. Eric Kandel, Nobel laureate, Dr. Tina Moreno from IBM Watson, Dr. Lalagam Shekar, who's a prominent neurosurgeon, and Dr. Sean Pakbaz, an interventional radiologist. So we look forward to provide you with more exciting information on Brain Channel, and thank you for watching Brain Channel.